First of all, in relation to adolescents, we use the term contraception rather than family planning, because while some adolescents may be using contraceptive methods to plan their families, many others are not. But that's a separate issue. The point we're trying to make here is you cannot talk about universal health coverage if you don't have adolescent-friendly health service elements integrated into national health systems. Otherwise, it remains a project. It could be a non-government organization project, or it could be even a government project with one municipality in one place. But if we want to integrate adolescent contraception into large-scale programs, then you need to do certain things that you don't do if you were running a small project. That's what we're going to talk about today. Now, what do you do in a country like Moldova or Ethiopia or Chile, which are in very different contexts, different, economic, social, cultural contexts, but there's a common thread in their work in that they've taken lessons that we have learned over the years in making health services and contraceptive services friendly and responsive to adolescents, but they've integrated it into national health systems. So that's what we're going to do. So what we're going to do is have Callie Simon, who leads the work on adolescent sexual and reproductive health and Save the Children, say a few words. Then we will have presentations from our three colleagues from these three countries, Moldova, Chile, and Ethiopia. And you will have a chance to talk to them and listen to them and learn from their work. So we will keep time after their presentations and at the end for discussion. Over to you, Callie.
Okay. Hi, everybody. Is this working? Great. My name is Callie Simon. As Chandra said, I am the Adolescent Sexual and Reproductive Health Team Lead with Save the Children, and I have the pleasure of giving you a brief overview of what we mean when we say adolescent responsive health systems. So can we share the slides on the screen? Thank you. Okay. I think if you're in this room, you probably already know that adolescents experience disproportionately poor health outcomes. Unmet need is higher, adolescents seek care later in pregnancy and are less likely to seek and obtain skilled childbirth and use postnatal care services. Adolescents and young people represent a growing share of people living with HIV, and half of all mental health conditions start by age 14. And the reason adolescents that adolescents experience disproportionately poor health outcomes is because they face unique barriers to accessing and using high quality health services, including sexual and reproductive health services. Many of you likely know the many barriers adolescents face. In this slide, we've organized them at the individual, social, and structural level. And I'm going to look for a moment together at that systems or structural level, because that's kind of what we're focusing on here today. Some of the major challenges adolescents face due to distance, fear of being seen and judged, poor treatment by providers, legal and policy restrictions, and many more. So for about the last 30 years, the evolving response to these barriers, especially at the systems level, has been adolescent-friendly services. Many of you likely know what those are. Many of you have likely been involved in programs or facility-level services or in governments that have implemented adolescent-friendly services. Adolescent-friendly services is a really important strategy. As it has been implemented and evolved over time, we have a body of work. We have quality standards, we have guidelines, we have implementation examples, and we have evidence that suggests that when implemented in line with those global standards and guidelines, it can contribute to improved access to and use of quality health services for adolescents. But none of us, I'm sure, want to remain static in what we've always done. We know that we have to continue to learn, to understand what's happening, and when appropriate, adapt our responses. So adolescent-friendly services, if you've implemented them, you likely know that often they have been implemented through externally funded projects, and often with a major focus at the facility level, meaning we often see adolescent-friendly services doing a couple of things like training providers at the facility level and setting up a corner or a room or a space for adolescents to come and receive care. Nothing wrong. However, it's been very difficult to scale and sustain that model of adolescent-friendly services. It requires space in a health facility, which sometimes isn't available. It requires that governments or whoever takes over after a project ends continues to use that space for adolescents, and it's been difficult to implement at scale. At the same time, as the theme of this conference suggests, we have an increasing emphasis on UHC and health system strengthening, and it's critical that we make sure adolescents are part and parcel of the UHC discussions and of health system strengthening. And if we don't include adolescents in that conversation, and if we don't approach adolescent health as a health system strengthening endeavor and as a UHC priority, then they will be left behind. So this confluence of factors, the challenges that we've had in scaling and sustaining, some of the challenges that we've had in making sure that adolescents are part and parcel of UHC and health systems means that it's time that we take what we've learned and we continue to evolve. And we embed what we know works for adolescents from 30 years of evidence and learning into the health system. And this is what we call an adolescent responsive health systems approach. In 2020, there was an update to the high impact practices enhancement on adolescent responsive contraceptive services. This enhancement described adolescent responsive health systems, as you can see on the slide, and it refers to making existing health services responsive to the needs and preferences of adolescents by incorporating what we already know into the health system rather than implementing isolated interventions. And it goes on to say that it signals an evolution from traditional standalone models of adolescent-friendly services towards a systems approach. But what does this actually look like? So luckily for us today, we're gonna hear 3 examples of what this looks like. I'm just going to briefly give you some of the framework that we are using to think about this. And we're using the WHO Health Systems Strengthening or Health Systems Framework. That includes the building blocks you see here on the screen. With the addition that we put of community, because we know how important the community is throughout each of those building blocks, especially when it comes to adolescence. And the idea is that for each of these WHO health system building blocks, we can make changes that make that building block more likely to meet the needs and prioritize adolescents. For example, within the leadership and governance building block, we can make sure that policy, standards, guidelines, and budget allocations uphold adolescents' right to health care. And we can ensure that mechanisms for adolescents to hold their health systems accountable, like budget review meetings or community scorecards or adolescent participation in community facility committees, are in place. Within the financing building block, we can make sure that adolescents and the health services that adolescents need are included in insurance schemes and other financing mechanisms. At the service delivery level, where we've already been working quite a bit on adolescent-friendly services, we can continue our work and making sure that adolescents have access to an integrated package of care rather than siloed contraception or HIV interventions, as has been the case in the past. And that care is delivered through multiple different entry points, not just necessarily a room or a corner, but through community health workers, through schools, and through other systems and places. Healthcare staff who interact with adolescents would be adolescent competent, not just through training, but through a series of supervision and mentorship. In the health information system, data would be collected in age and sex disaggregated ways, and most importantly, used. And all commodities would be available without restriction. And finally, with the community work that we've been including, we make sure that we consider the community element of each of those health system building blocks. And in addition, the health system can work with other entities to promote school health, as well as to link and coordinate with education sector and others on things like CSE, comprehensive sex ed. So now I'm actually going to wrap up. That was the what are adolescent responsive systems, but it's much better than listening to me to hear from the country examples. So I'm going to pass to Chandra. Thank you. You actually don't need that.
Thank you.
Thanks.
So in many countries, many of you may have experienced, we need to start making services, our health services, adolescent friendly. So what do? We do training of health workers. We put a notice board and say adolescent friendly clinic. And then we are surprised that no adolescents come there. And that studies show that that health workers are not responsive. So we've all made those mistakes. It's not as if you've made those mistakes and we knew everything all along. It's been a journey for all of us. Galina is one of my heroes, one of my long-standing friends. She lives and works in Moldova, a small country, ex-Soviet Union country, completely disrupted at the end of the Soviet Union, and now disrupted because of Putin's cruel and stupid war. But what Galina has done is moved from an adolescent-friendly center to an integrated approach across the health system of the country. Let's listen to her story. And one important point, please come, Galina. Moldova is not a very rich country. It's very easy to pull up a high-income country and say they've done it. Chile, of the 3 countries, Chile is the most high income. But all these countries have found ways of doing this, the systems approach that we've described. Over to you, Galina.
Dear Chandra, dear Kali, thank you so much for this opportunity. I'm very honored to present our experience and to share with you our lesson learned during the last 20 years. Started with center what I coordinated just this year, graduated or have anniversary of 20 years. You see where it's Moldova, just in case, not in Africa, not in Asia, it's in Europe, it's very small country between Ukraine and Romania, and have a population of 2 and 6 billion population. Could imagine 30 years ago when start independence was 2 times higher, decreased due to this huge social crisis in what we call the demographical crisis due to huge migration, travel migration, decreasing natality in end of 19, increasing mortality. Now it's stabilized. And you see a proportion of young people, it's also decreasing. And as many of you, we passed through the COVID, very hard crisis, and now this year one crisis pass in other humanitarian crisis. Moldova, it's a small country in concentration of refugees from Ukraine. It's highest in whole neighborhood country. This is our context. And I will use the same approach of WHO blocks to present what we following to build this block in our health system during this period. First of all, of course, it's very important to start with good supportive policy. When was done in beginning of 2000 situational analysis and clarify a lot of problem due to such big crisis, unwanted pregnancy, STIs, that's everywhere, was developed a set of politics. I not will list you, in many countries it's the same, starting with law and finalizing with national program in sexual and reproductive health right and health. Also, defined a clear normative framework for youth-friendly health services, a clear package of services for adolescents, and I will told later on about some examples. And was developed quality standard for such services, what help us to organize process. And in conception, in view of developing youth-friendly health services in our country, of course, started as in many countries from few pilot centers. One of them was mine. But we, step by step, come to have such small centers as like a part of like a subdivision of existing primary healthcare institution, and like a entry point or like a big open door in the system for adolescent where work multidisciplinary team of specialists, and for adolescent it's more easy to come in the system through this door. And also this is one part of services. Other part it's to make every family doctor practice more adolescent friendly, and how to change communication with adolescent and some services in basic package. And of course, one important issue since beginning for us was involvement of young people, and they are involved in such services through our, we name it UK or Youth Clinic volunteering program. We have in all this team or multidisciplinary team always exists a team of young people who participate in everything, since planning till monitoring and evaluation. This is related to leadership and governance. Financing, one of the big achievement of our country is that since 2008, our medical insurance company, this is state medical insurance company, started to finance these services. And initially was very slow financing, but we did a few financial evaluation, and this helped us very much to increase and to have enough argument for insurance company to increase our financial support. It's not enough even now, but it's much better. This is one issue. But from other issues, our government cover all health insurance for all children, all students, all pregnant women. They insurance, they medical insurance and services for them in all institutions, not only in youth-friendly health centers, are free of charge. And also the same, it's services for people who from K population, especially living with HIV, treatment is free of charge in any institution. And now in other issues, I already start with finance, but it's very linked to commodity and logistics. Our state started to procure from state resources contraceptive, the quite large list of contraceptive, but it's available at the family doctor, at the youth-friendly clinics for any adolescent and other population. This is about financing. It's not enough, of course, but some basic package it's already assured, and this is very helpful for us. Service delivery, as I already present you, we have extended package provided by youth clinics, and the basic package or friendly approach what we started to be provided by family doctors and hope will be introduced in any medical institution. And we, in our approach to organize our services based on WHO characteristic of youth-friendly health services, effectiveness, appropriateness, and etc. We try maximal to adapt these services to real needs of adolescent, and consulted even our quality standard. We consulted with adolescent. Human resources. This is just to be shortly. Of course, we started as everywhere with training, but finally we come to what we now, we are a small country, and for us it's more easily, we have only one medical university, and we supported this process of revision of curricula of medical university at the postgraduate and residential program for pediatrician to include courses in adolescent health, and students also have visit in youth-friendly services. This is one issue. Second issue is we, due to support of many donors, in process of scaling up, we trained almost of family doctor from the country, resource person from the communities, but it's not enough. because one training not solve very much. We introduce a supervision system in place, and each month our centers organize supervision meeting to continue to have like a supportive supervision, and also periodically our local youth clinics in local areas, they organize collaborative learning meeting. It's not costly, not require additional budget, but keep all person in touch with new in adolescent health. This is about human resources few issue. About health information, and here we based on our medical statistic, especially we have a separate statistical form in informational system for youth-friendly clinics, and we have some data, and also we have behavioral research, HBSC, CAP research, mix, and what help us to organize and argue politics and monitor them. And also we have some evaluation of services itself, like coverage, like quality evaluation and costing. And about commodity, I already told a lot. We are very proud that finally, during the last 4 or 5 years, our state started to procure almost needed commodity, starting from rapid test for HIV, syphilis, and finalizing with medication for syndromal treatment, contraceptives, and these basic needed commodities. And of course, parallel with this, we work with community, especially to inform adolescent, and here help us very much our volunteer, who is the most active promoter of the services in community, and also we have a parental program. This is just to show you this process when we started big scaling up process. First centers was, as you see, in 2002, 2003, and since 2008 they become, initially they was a project. But since 2007, they become a subdivision of existing medical institution, primary health care, started financing, and in 2011 we start to do this big scaling up to have accessible such services in all territory. And you see about our package extended and basic, and very important to mention that our services are not only about reproductive health. This is very comprehensive approach, result oriented, and we have 7 priority problems that you can see, mostly of course related to sexual and reproductive health, mental health, nutrition disorders, violence related problem. And you see main direction of activity, it's different a little bit, and we change everything, even norm of time for providers. It's not only consultative, but a big informational educational activity. And when we started this process to have everywhere accessible services, this is again on vertical, everything what we mentioned, and horizontal way. And you can see some result. Last year, even in pandemic situation, we continue to promote to have our services and keep them at the level of 70% before to level of before pandemic. And you can see this process of scaling up during the 8-7 years. And last year, 30% of 10-24 years old population was covered by services, youth-friendly services. And as a result, you can see our dynamic of adolescent birth rate, adolescent abortion rate. It's decreasing. Last year, it's continued to be more than twice higher than mean of in Europe region, but have clear dynamics. And in the same time, increasing use of contraceptive among 15 years old sexually active adolescent. And we told a lot about lesson, but it's very important to base intervention of evidences and best practices. And here help us very much WHO since first step when we use this opportunity to express our gratitude. Use the systemic approach. When we pilot something, initially it's good to think since beginning about how we will scale up. Advocate. Me doesn't imagine that advocation need to offer such big time. It's very important to keep network. It's very important to have supporter in different like K supporter. It's very important to build critical mass of professional, involve adolescent, and in crisis first ensure safety and morale of staff. And sometimes things not move forward, just keep going. Sometimes we are tired, and this is also normal. And taking this occasion, I want to express my my gratitude to all people in Moldova who was involved in this process, to WHO, and to many donors who supported us in this process. Thank you so much.
Thank you, Galina. I'm sure you've taken many messages from this, and if you're interested, the presentations are available. But I just want to point two things. One is they worked very hard to make sure that adolescent health was integrated into health insurance systems. And it was not easy. They had to do costing studies. They had to convince the finance ministry. That was one. The second thing is they decided very early that they're not going to spend 80% of their budget on training health workers. They trained health workers, but then they brought them back again and again for retraining on an ongoing basis without paying per diems, without putting them in a hotel for 5 days, and improve their capacity on an ongoing basis. Before we go to Lemessa, any one quick comment, question from anyone? Please jump up quickly. I think you need to speak into the mic. You can either speak there or come here, Kiki.
You can use it.
If there's one more person, please come.
Hi, everyone. I'm Kiki from Kessel from Save the Children. I have a question for you, actually, Chandra, because you just mentioned, without paying per diem, etc., you brought health staff to train and retrain. And in some contexts, I find it very, very difficult to even get people on the table, for training without paying them per diem, specifically in lower
very good
middle
question.
income countries.
Even if you pay people, they don't come. How do you make people come without paying? Your question, please. Just introduce yourself first.
Of course. Hello, everybody. Tamar Chitashvili, practice area lead for women's, children's, and adolescent health, management sciences for health. Thanks, Galina, for a great presentation. Coming from Georgia, we have very similar issues and problems. One question about the package of services. Did these adolescent-friendly services include family planning, reproductive health only, or broader package of health promotive interventions focused on NCDs and like behavioral practices? So this is one. And second, in the context of increasing influx of refugees, how the country address the problem of reaching the refugees with these services? Thanks.
Okay, just a minute. I can answer one question. It was not only family planning, it was a broader package of services. The question about refugees, let's leave for now, because we have to talk about that for Ethiopia, we have to talk about that for Chile as well. Let's see how they're dealing with migrant populations. But the first one, can you answer, Galina, about how do you get health workers to come back?
Of course, first of all, it's good training, 3 days, 5 days. But after supervision meeting, we have a very short one, half of the day. And we have, in our country, it's very hierarchical. Ministry of Health order in beginning of the year, and according to this order, they and this is one issue, but other issues we included need to participate, but they should participate in description, in regulation of youth center, in the job description. But in regulation of the center, in the professional job description, but they should attend regularly such kind of meeting. And this is one component of quality evaluation of the center.
Thank you, Galina. My colleague from Georgia, I'm not, your second question, I think I've answered. If you want more information, please come back. Come on, Lemessa. Let's hear from Lemessa about Ethiopia. We will have time at the end for discussion. You can also stay on if you want to talk to our colleagues here. So Lemessa is an associate professor from Haramaya University in Ethiopia. He is also part of the technical advisory group associated with the Ministry of Health. not this one, the Ethiopia case study, please. So he is another long-standing friend and collaborator of WHO, and he's going to describe how Ethiopia, which was a country, if you remember in the past, a basket case, famine, civil war, and within 15 years, they transformed the health system and achieved dramatic results.
Thank you very much, Dr. Chandra. Are you alert?
Yes.
It's almost afternoon, yeah? So because we are talking about adolescents and young people, so we need to remain young, yeah, throughout the presentation. So I hope you know where Ethiopia is located. Ethiopia is located in Eastern Africa, and it is bordered by Kenya in the south, Djibouti in the east, and Djibouti and Somalia in the east, and the Sudan and the South Sudan in the west, and the northern is actually Eritrea, which used to be part of Ethiopia once upon a time. So why did the Ethiopian government actually focus on adolescents and the youth health? These are some of the justification following the ICPD, International Conference in Cairo, which is a commitment on reproductive health. And after achieving actually, Ethiopia achieved child goal targets well ahead before actually Millennium Development Goal Parade Index. Then Ethiopia thought about the life cycle approach, because now those children are going to be adolescents. What preparation we have actually for those children who used to be healthy during childhood, so we need to continue through the life course approach, and then we put such efforts. So Ethiopia is also the second almost populous country in Africa. So with the young adolescent population, 33% of the population are 10 to 24, and the 5% are actually adolescents. So this argument and the impact of adolescent age group again on the contribution to maternal mortality was also well taken into account, and that is why Ethiopia also focused on this. So from the adolescent-driven, evidence-based driven building blocks, then the leadership is one. Now, the leadership Ethiopia took is reforming some policies, authorize the provision of contraceptive for young people, and oblige health workers also to provide them when they demand. So these are some of the engagements. Then another is the youth-led organizations are represented in adolescents in a technical working group again at national level, and also that is cascaded to some regions as well. Youth engagement guidelines were also developed to facilitate these, and the meaningful youth engagement guideline standards were defined, and they are supposed to participate starting from the design up to implementation, monitoring of the programs that affect adolescents and youths. One area also of the building block that is driven to adolescent aspect is the financing issues. For this, Ethiopia did mandated provision of contraceptives to adolescents free of charge in all government-run facilities, actually, in all government-run facilities. Another area is the medical product, obviously, that is the vaccine, the supplies technology among the building blocks. Ethiopia did some bold measures again here. The government again procured contraceptive programs as part of the national wide efforts to strengthen the health system in general. And this is not actually unique to adolescents alone, but adolescents actually benefited from the Ethiopia's huge effort by mobilizing partners and by also allocating funding from the government. Data were again, this is I just passed this. As a result of these efforts, then a range of contraceptive methods were made available to everybody, actually, including adolescents. So adolescents also benefited from this. Health information is one aspect of this component. Age-disaggregated data indicators and contraceptive utilization were included into the HMIS, now into DHIS2. Ethiopia also transferred into the DHIS2 now indicators. And age and sex disaggregated data on SRH and other the key health issues of adolescents, not only SRH issue, key health issues of adolescents were also integrated and they are reported at all levels of health, and they are also used to inform decisions at all levels, not only at the national level, but at all levels of health system as well. Another bold effort Ethiopia took is related to the workforce. The national adolescent training materials were adopted, that is from the WHO, and that is developed and adopted, and with this material already prepared at the national level, more than 1,800 health workers actually took in-service training at national level, and adolescent sexual reproductive health components was incorporated into some pre-service education training like midwifery, nursing schools, among others. These revisions were made. Then when it comes to the implementation level at facility levels, during monitoring, there is a national monitoring guideline that also incorporates integrated and targeted monitoring and supervision of adolescent health targets, and adolescent-specific supportive supervisions were also made, and on all service outlets that's supposed to provide adolescent health service again from the national. It's not only training, but also during the monitoring as well. Now the service delivery points is one of the bold measure actually that Ethiopia took. The government of Ethiopia actually make it either service outlet for adolescent and the young women because they can obtain from the nearby. Ethiopia expanded service outlets widely, greater than 400 hospitals, and greater than actually 3,600 health centers, and more than 17,000 health posts were actually built in Ethiopia. This is during the reference period of actually 2016-17. Now it is far more than that. It is far more than that. And during this period again, 46% of at least these health facilities were already reported to be youth-friendly, providing youth-friendly services. Now it is more than 50% already. It is around 52% are actually now currently providing youth-friendly service with the recommended standard. And Ethiopia also took bold efforts in training local community health care providers at all village levels. Almost these are at the village levels. For 2,000 health extension workers were trained and deployed to improve access to especially very essential health service at community levels, and from which actually adolescents benefited. One other component which is not part of the boldly as such in the WHO adolescent-driven component is the adolescent demand and the community support of the adolescent service provision. So the government undertook here key actions that ensured that adolescent girls and the young women and the couples aware of the contraceptive service offered, and motivated again them to obtain these services, and that the communities are actually also supportive of this service provision at all levels. And this is done through health extension workers. Usually these are the health facility staff are trained, and they are also deployed at the community level. They educate adolescents and young women about the benefits of safe motherhood and the contraception, and about where and how they get these services when they demand. And these health extension workers are instrumental actually in most of the ensuring access to facilities and access to information and service at rural community level, especially. Rural community in Ethiopia is where more than 80% of adolescents actually live. It is not, Ethiopia is more of urban centered. So what are at least the achievements so far then, based on these different efforts that are made? If you look over the years, the blue one is made contraceptive for adolescents over the years starting from 2000 to 2016. So there is almost linear increase of the access to contraceptive, need for contraceptive, and the unmet need for contraceptive it was almost nearly 40% during the beginning of the year. Now it is declining, but it is, we don't say it is still down there. So what are the key messages from these interventions then? These are some of the key messages. 29% increase in contraceptive use by married adolescent girls at least from this during the period, and 8% increase in postpartum contraceptive use. It used to be around here, around down 3%. Now it is nearly 6% actually this time around. Then a 3.8 decrease again in adolescents who have begun childbearing between the parents. The childbearing is very much struggling. It is not very much effective. Then when we are not about at the stage still to celebrate our achievement, we need to do more because the achievements are also very marginal, and we need to do more and sustain the gains and actually achieve more. That is where we are now. And this presentation is just sorted from this material, which is a case study that we already published, and it is available online for you. Thank you very much.
Please stay, please stay. So let's give him a big hand. I just want to make 2 points here. One point is that one of the bold things Ethiopia did was they put health extension workers, 42,000 health extension workers from the community, taken on, trained and paid for by the Ministry of Health to expand service provision and also to change norms and knowledge in the community. So, you know, bold actions like that. And although you see rapid increases in contraception, childbearing rate decline is less because early childbearing, the childbearing moved from very early in adolescence to later in adolescence. So it was still in adolescence, but it was much later in adolescence. And I think, like he says, the key issue is to wait. We need time to show these results. And that's one of the key messages. You will see that from Chile as well. There are no magic solutions in 2 years or 3 years. If you want large-scale change, it takes time. Any one question, one comment, please come. Come quickly, come running.
The mic is also working there. The mic there is also working.
Introduce, face everyone, introduce yourself.
This one.
Thank you. Yeah. Hello everyone, myself Aman Chug and I'm from Engender Health India. So one question, recently during one of our projects we had this rapid assessment done. So regarding the, I have a question to both of the speakers regarding the trainings. Yes, regarding the trainings only. So you said that you provided trainings to the healthcare providers. So my question is, what kind of trainings did you provide, like only the technical parts in service trainings, or there were some aspects of being sensitive towards the adolescents providing care, like how to provide care through that side, because at times even adolescent fears to reach out to the healthcare provider because of the judgment issue, privacy and biasness and all those. So that is the single question. So if you, and regarding that, if you have developed any training materials regarding that kind of training towards being sensitive and all those things, I would be happy to have those because that would be a great resource for us. Thank you.
Hi, my name is Yassine Bai, and I work with FB 2030. So my question is specific to Ethiopia. You mentioned that 80% of the adolescents and youth are in rural areas. So I was just wondering, in terms of reaching these populations, does Ethiopia focus on any type of mobile clinics? Mobile clinics?
They use a mobile clinic.
Mobile clinic.
Yes.
Okay, so the question about training, just like the question on mobile populations, we'll keep to the end. But why don't you have a quick answer on approaches you to reach people in the rural areas?
Thank you very much. Let me respond to the first question as well. One part of the training we have is already, it's a kind of in-service training. It is an orientation training. From the orientation training, we are just focusing on what are the special needs of adolescents that we need to take into account. It is because for health professionals who have the basic knowledge of medical education or nursing or whatever, then they have to apply in a sensitive way for adolescent needs, developmental. And the adolescent communication is one component of that. And we have that material, maybe a PowerPoint material that you can share online. Regarding to how to reach the rural community, one of the approach of the rural community target is based on the health extension training is to ensure access to that. Mostly these health extension workers are trained from the local community, from the local population, from the district, and from the who know the local cultures and the local language and the customs as well. So they will receive nearly minimum of 1 year training, and they will be deployed in the same community in the rural area as well. Yeah, they are paid, they are salaried. They are salaried and they are paid, and they are not, that is not a voluntary service. So that is one approach. And for even the mobile, there are population groups which are nomadic or which actually change locations. For that, actually, we included male health exchange work. Mostly in the agrarian and the settled population, female health exchange workers are trained. In the agrarian, where population actually regularly change their addresses, male health exchange workers were trained so that they can be physically fit, and they also will not encounter themselves to the different SRH violence or whatever to themselves alone as well. So that is what Ethiopia actually did, and thank you very much for your question and the interest.
We'll wait after. Matilde is now with the University of Santiago in Chile. Before that, she had a long, illustrious career as a regional advisor for adolescent health in the WHO Office for the Americas, the Pan-American Health Organization. So another long-standing friend, colleague, collaborator. Another wonderful case example.
Okay, thank you, Chandra. Thank you for inviting us to present a successful story of a 60% decreasing in adolescent fertility rates in 10 years in Chile using the system approach and adolescent responsive contraceptive service. And we are going to answer two questions today. The first one, what actions did the government of Chile take to integrate adolescents into the health system? And the second, what changes have happened over the time? We're still using the same framework of building blocks. So leadership, governance, and political will is crucial. We established a national health system during the 1952, but we were able to institutionalize adolescent health program in the 90s. Then we realized that adolescents are different from other age groups, and we established the National Adolescent Health Program in 1996. In 2008, we have a national policy, and here comes the key issue. The other friendly youth spaces were established 2008. For planning in our country, the national strategy in 2011 include as a target a reduction of 10% of fertility rate in adolescents. That secured the funds. So the government leaders have been very active in addressing the barriers for the use of contraception, and we have advanced legislation. Even adolescents less than 14 can have access to contraceptive in my country. And in 2010, youth participation was established, and a national council and youth council was established as an accountability system, as advocates for sexual and reproductive health, and to help disseminate the new policies, programs, and services that were in the local level. Okay, financing is key. Services for adolescents in Chile and contraception are free of charge because the Chilean government has a universal health insurance. You can choose private or public, but most of adolescents are covered under the National Public Health Insurance called FONASA. You can see in blue in the first block there that 80% of our adolescents are under the National Health Insurance. And the budget for adolescent targeted services for adolescents has increased over time. If you take a look in adolescent-friendly spaces, we started with 4,000, and now we have 6,000 million. We include money for, of course, for immunization, HPV, a big chunk of money, so it's free of charge now. And for adolescent and reproductive health, since we were successful, 27 million, 1,000 million were included in our budget. So when we started, we have small amount, and we start doing better. Health services delivery, the key word here was integration. Chilean government moved away from silos, and they have a variety of health services delivery models, not only one, but adapted to adolescent needs. So in Chile, there is a central package of services that can be included in the top there. They can be included in the primary healthcare facilities within the family care model. You can be seen by a doctor or by a family doctor, and also it's included in the women's program, so you can be seen by a midwife. So this was the first level. And the implementation of friendly health services come in. These are friendly spaces located in the primary healthcare facility or in the schools. These friendly spaces provide sexual and reproductive health services and mental health services. Very important because it's a little broader than only sexual and reproductive health, and the characteristics are they have the fair hours to attend for adolescents. The second one, they have trained providers, one midwife, one psychology, and the third one is depend on the adolescent needs. They can have a social worker, a nutritionist, or other psychology. It depends on the demand. Very important, these friendly spaces were established in those communities with the highest adolescent pregnancy rates. So we prioritize so we can have an impact. And of course, we still have adolescent service in the tertiary care, but these centers are used for pre-service and in-service training. Between 2008 and 2020, we add 294 new spaces for adolescents. We went from 54 for 348, almost with national coverage. And you can see here the increase we had in 10 years in the coverage of adolescent health control with full access to contraceptives on demand. So the healthcare workforce, we train our staff and the providers in competencies, and here's the answer, in implementing high-quality health services. So confidentiality, respect, privacy, empathy, and bonding is one of the main issues here, so we can have trained personnel with these competences. We have several guidelines and training materials for the comprehensive healthcare. And also we have modules for counseling, for training and contraceptive method, and also sexual education. So this midwife in these friendly spaces goes to schools, goes to the community, and trains schools, and of course, adolescents. Chile has a very good information system. We really collect, compile, and analyze age and desegregated data by ethnicity and by migration also. We do that in the district, in the regional, and the national level, and we have indicators of adolescent health included in all our Ministry of Health indicators, monthly statistics, and the health surveys. Very interesting, for the first time, Chile is going to be conducting the health survey for children, and they are going to include 10 to 14, and we're going to have data on that group. And from the primary health care in the clinic after, we use a standard form so we can collect data. That standard form is called the Center of Latin American Perinatology Adolescent Information System that is used in the primary health care level, and also the National Institute of Health of Youth conduct a survey every 3 years. So what change have happened? And here's the good news. This is the percentage of adolescents 15 to 19 that use contraceptive at the first sexual intercourse. in blue 2006, in yellow 2018. We still have a high use of condom, and we're very happy about that. We have been telling adolescents to use contraceptive for double protection, and you have in male on the left, in girls on the right, but the most important issue here is the increase in modern contraception in adolescents. They're using much more the pill, they're using the emergency contraceptive, and they're using long-lasting contraceptive. I think this is the motor of the changes we are facing. And this is the most important achievement. Here you have the fertility rate in adolescents 2005, 2020. You can see we have seen a 51 reduction of the proportion of birth to mother under 18. But the most important issue here is the reduction in the fertility rates. In green, you can see the fertility rates of 10 to 4 to 19. But this change is completely driven by the reduction in fertility in 15 to 19. In green, you can see there, in 2008, 54, in 2018, 22, and now it is 15. So we haven't changed the fertility rate in adolescents 10 to 14. So we have to maintain and decrease the pregnancy rates. We still have 4 times the fertility rate of Spain and 5 times the fertility rate of the Nordic countries, so we have a long way to go. We are prioritizing 10 to 14. It has to be 0. We have to advance friendly spaces and services for adolescents. We're evaluating these services. Something very important is to achieve universal coverage, we need to address inequities in and the geographic gaps. Still, adolescents have 4 times more risk when they have 5 years of schooling compared to adolescents who have 13 years of schooling. So there's a big gap there. And the other gap is if you compare the high-income communities with the lowest community, the risk of adolescents in the lowest community to get pregnant is 40 times, 40 times. So the government is addressing this issue. We need to take in consideration the inequalities and do not leave any behind. We have a big challenge to include males, to address some specific barriers in migration, and we are going to talk about, and of course, we have to do much better in comprehensive sexuality education. Thank you very much.
So, I've been in the adolescent health field for a long time, and initially people would say to me, you have these nice projects, but where are the programs? Now we have programs from Ethiopia, from Moldova, from Chile, and we are in the process of writing one from Thailand. So we have large-scale, population-wide changes. You can bring about changes in adolescent health, but it takes political leadership, it takes actions. So why don't we invite Lemessa, Galina, and Matti? If you have any questions, I mean, you've raised the question of what do you do with migrant populations? We can have this discussion on health worker performance. Increasingly, we are not talking about training. We are talking about a focus on performance, using various approaches, including training. But we know that training on its own is a waste of money. Okay, any comments, any questions to Matti or the rest of the group? We have about 15 minutes before the end of the session, so you're very welcome to share a comment, share questions. Anyone wants to come up? Please. Please introduce yourself and ask your question or share your comment.
Thank you so much for giving me this time. I'm coming from East Africa, Burundi, and my name is Sonia Akimana, and I'm working in a local organization. And I'm working on family planning advocacy. And my question is this: how do you work with a really strength culture and religious thing? Because sometimes the government may write on papers that adolescents can get access, but it's really tricky because when on the land we are working there, it is really hard and difficult. I just want to know, I'm addressing, I'm sorry, I don't remember the name, the lady in pink color, I'm sorry. I just, yeah. Yeah, I just want to know, how have you overcome that? I don't know in your place, but how can you get the permission from the government to introduce adolescents to get access on family planning in a very controversial place?
Thank you. You've raised two questions. One is, how do you get governments to put it in a policy?
Exactly.
And secondly, from a policy, how do you get health workers to translate that into action? So why
Yes.
don't we get them to answer that? It also ties in with the question from our Indian colleague about training health workers.
Yes.
But you have one more question.
Yes.
Go
And
ahead.
how? Yeah. Because it's really hard because that's what I'm working in.
Yeah.
And I just also want to know, because sometimes the health care facilitators, they are the ones who do the barriers. Sometimes, I mean my country. Because adolescents may go there and they are the one to spread that, hey, this one came to me and they are seeking for this. So how to train them better so that they can work on the confidentiality in their workplace? Thank you.
Thank you. Why don't we now have your comments, questions, please?
Maybe you will start, Matilda, about this.
The name is already called.
Okay, thank you for the question. You know, we are a Catholic country, but the good news is that the Catholic and the Church are separate. We don't answer to them. We are completely separate powers. It took a long time. It was not easy. It took a long time. I think what helped us a lot is advocating not only for the policy leaders or political leaders, but also in the public arena. So we convinced that adolescent pregnancy was a problem for Chilean advancement. So there we start talking, we still fight the Catholic Church. We're still fighting, but now that we have been very successful, nobody wants to talk and said anything.
In our country, we are Orthodox, not so strong, but periodically appear some wave of opposition. First of all, it's need to make advocacy to find in between religious leader some supporters and start with them to explain that we have the same goal, to have happy families, to have and find some common position and start with this common position. One example of common position is violence. We against violence and we want strong family, we want wanted children, and start from this way. It's very important to start dialogue in way to find the common position. This is one, but need to be prepared, but it can be long term. And as a compromise can be online services, and now telemedicine offer a possibility to do online abortion through the online services, and this is need to be developed in such a setting from experience, international experience. About training program, what I want to add, there is few very good sources or platforms what we use in our trainings. First of all, and Lemesa mentioned, this is WHO orientation program, it's actual. Second one, we use very actively and a part of, in Europe, there is UTeach, European teaching program in adolescent health, but it's very based and it's very important to change attitude. Of course, first of all, it's need to do orientation. This is more technical, but it's very important to have in deep module in communication and even in solving of case study, and we use a simulation patient to situation, and our volunteers play this role to help us in training, especially when we train new doctors. And this is few platform what you can use. You teach have all presentation available. This is about refugee. What we developed in refugee crisis, few new services. We put a lot, if in pandemic crisis we developed a lot remote services, online services. Now we are developing outreach services, especially we now started to pilot 2 mobile clinics, mobile car I show on the pictures. And a lot of outreach work in a setting where refugees are placed. It's not very easy, but first of all, we start with safety of our staff and to prepare it and to have clear tool to keep them resilient. Thank you.
Maybe one quick input as well. Thank you very much. I wanted to just comment about the challenge from the religious society and the culture. In a traditional society, it is a common problem in most of us as well in Africa, even in Ethiopia, we are regularly challenged with that. What it needs actually is commitment to champion change from the providers, health professionals themselves. Sometimes health professionals themselves also blame that they will be prevented or they will be objected from religious providers and they don't show firm initiative. If you have a firm initiative, you have to convince to choose between 2 evils. If you don't do your intervention, if you don't inform and provide service for intervention, abortion, or even the consequences, loss of life, maybe, in most cases. So you have to choose between this intervention and you have to engage them, not only one time, you have to champion, I assure you they will be changed and they will be convinced. So that is how we will really do and overcome some resistance from religious organizations and from traditional organizations. So that is what we need to do. First, change providers' attitude and providers' commitment to champion the health of adolescents. Thank you.
See, Ethiopia reduced child marriage, reduced FGM, female genital mutilation, increased contraceptive uptake, increased hospital-based attendance, increased antiretroviral treatment for people with HIV. The one thing it didn't do very well yet is address gender-based violence. So, you know, this is a package of actions challenging social norms. A quick comment, then I want to have
Yeah, I want
comments
to
from the
make
floor.
a comment about training. I highly recommend to train the providers in legal aspects. So what are the legislation you have in place so you are protected, and in ethical issue, if you so they can use their values, you know, and we can respect them, but still you need to train them in that. And the other issue about migrants, remember, Chile is a socialist country, so every migrant that arrives in my country have access to the national health insurance, so nobody is left out.
Okay, I want to hear from the floor. Brian, what's the one message you've taken away this afternoon?
I guess advocacy, working with governments, and yeah, training of providers. I think that's one thing that.
Brian works with IPPF. Can you introduce yourself and say what one message you've taken away?
I am Dr. Jacqueline Fonko, and I work with FP 2030, managing the adolescent and youth portfolio. I have taken away what you've just said about training providers on legal aspects is something that we notice in Cameroon, so I really appreciate that. And working with a health system approach, not doing just silo service delivery.
Many health workers in many places, they believe that the laws are much more restrictive than they actually are. And if you actually tell them about the laws, they say, aha, is that so? You're smiling brightly. What was your message? Introduce yourself.
Yeah, I'm Dr. Amit Yadav from India. I work for Mamta Health Institute for Mother and Child. So I think, you know, the biggest takeaway from this is that India is a large country, and, you know, we were carrying out this adolescent health friendly clinics and everything, and slowly progressing, you know, to total coverage. And suddenly, you know, all these reports where the whole facility approach, where all the providers need to be well sensitized on adolescent health issues, has to be taught, not just a corner in the facility, you know, which is segregated for the adolescents. So I think it's a great challenge for the Indian diaspora that, now we have to suddenly talk about that, okay, from that corner, it has to spread to all the facility. And so, and with all these, examples, it will be easy for us to, showcase these studies and case studies in front of the government and, kind of espouse that we also need to change.
Thank you, Amit. It's in many countries. You get one health worker trained, you keep a little corner and put a board, and then you tick off adolescent-friendly health services done. We've seen from these countries that's not how it works. It also takes 15 years to do these things. Kat, what's your message?
I knew he would ask me. Hi, I'm Kat Watson. I'm an independent consultant. I've been working with Chandra for many years on adolescent sexual and reproductive health. And I think my takeaway is that this is a process. Actually, when I looked and you said 30 years of adolescent-friendly services and corners and things, that actually perhaps those things were needed to begin with as a first step, and that it's not about we jump straight away to adolescent responsive systems across all of the building blocks, but maybe each context needs its own step-by-step approach. So that's my takeaway.
It's a journey, and sometimes you need to do the learning, and you need to do that. So you're right. Very interesting. And of course, each country has its own system. Any thoughts to share? Abednego, come on. A360, you have to share.
I think the key takeaway is that you have to look at the serving the adolescents through a system approach. And you want to make sure that you are not just focusing on delivering the service, the method, but you are looking at all other propping elements. And that's why the building blocks provides a good framework for ensuring that all the aspects are well covered, including policy and commodities, which is one of the biggest problems currently we have in Africa.
Thank you. And not just in Africa, in many other places. Any volunteers from here to share any thoughts?
For me, I think I'm Sangeeta from Save the Children Country Office, Nepal, and I think for me the takeaway message here is convincing the government actually, because if you want to include it in programs, it's important for our governments to understand that we need the systems approach, and we are still implementing some adolescent-friendly services approach in Nepal. So I think for me, that's my takeaway. Thank you.
Thank you. We'll have one last comment from the floor, and we'll ask our participants, our panelists, to close with some closing comments from each of you.
And I'm Joseph DeGraff Johnson with Save the Children, following another Save the Children.
Which country?
Based at Washington, D.C. And what I learned is that we need to stop doing small projects to support adolescent health. We need to start working with the national system to make sure that adolescent responsive services are implemented at scale. We have a lot of small projects, but we need to move. Even if you help the national system move an inch, I think it's better than having a small corner where you do a small project. So let's all put our hands together to scale up adolescent responses.
Thank you for your comments. I mean, I think if we want to see the population level changes that we saw in each of their cases, we have to work at the national level. But I think as Kat said, you have to begin. Galina started with a small NGO in Chisinau, the capital city. It has grown from there, and you need the time to learn, but you also need to know that your pathway has to be integration into health systems. Okay, why don't we take a minute each for each of you? Share your one thought.
Thank you so much. Related to training, I want to add there is global competencies, list of competencies, but there is basic competencies, including knowledge about adolescent health, legal framework, and other specific competencies can use it by base for training. But in general, I am agree with the postulate that it's need time, any consistent effort, and to know very clear where we're going. And it's need to start from smaller one. It's not possible in one day to make tomorrow and make all system friendly. In our case, it's not finished work. We have also a lot to work, but it's process, long process, and time consuming, energy consuming.
Okay, thank you. No, I just want to make a comment. I think that the system approach is very important for health services, but we need to keep in mind that this is not a magic bullet. You have to work intersectorial, especially with education and especially with social protection. You need to keep in mind who is left behind and which inequities we are having, so we can do better in those who are disadvantaged.
Thank you very much. Yeah, like we discussed actually, adolescent health is not something that should be interrupted, because we talk a lot about neonatal health, starting from contraception. If you go down, child health, now they grow and they become adolescent. So what package of service you have to make them transition to adulthood healthy, and then be healthy families or healthy family leaders? Then that goes to the next, that have an spillover effect for next generation of childhood again, because they are going to be parents next time, sooner or later. So we need to think adolescent health is actually a key to population change. If you intervene on adolescent health, and if you have healthy adolescents, you have healthy future adults. If you have healthy future adults, you have healthy next generation of childhood. So it has much population level impacts, but a kind of piecemeal approach, just addressing small adolescents who just presented to youth and they received or collected some contraceptives or some services, is not enough. We have to think of covering the whole population of adolescents. That is the right. And we healthcare providers have obligation to do so. Thank you very much.
Thank you. Okay. We've reached the end of our session. I want to thank all of our panelists and thank Chandramouli for moderating. Thank you so much for making it such a dynamic session. We are on this journey together, and if you are interested in working on responsive systems, come let us know. We're working on documentation and scaling and figuring out what that journey is, as Kat said. So come talk to us. Thank you.